Thank you very much, Dr. Feldman. Dear colleagues, ladies and gentlemen, first of all, I would like to cordially thank SAGES and organizing committee for inviting me to speak with you. I think when you see the topic of my speech, effective teaching in a simulation environment, is very difficult to cover in 15, 20 minutes. It's a huge topic. So therefore, I'm not going to actually go into introduction and dive right into the subject matter. So if we can think about how do we achieve effectiveness in teaching in a simulation environment, two factors come to my mind. One is to choose effective methods of teaching in the simulation environment. And second is to design criteria for effective teaching in a simulation environment. So what I'm going to do is actually look at each one of these separately and summarize them separately. So first we are going to look at the methods. As you probably all know, that medical education, the famous methods for delivery is chalk and talk, which is seminars and lectures and all that, reading books, and also apprenticeship model, which is see one, do one, teach one. A friend of mine is calling this see one, do one, kill one. Now, we do this, but if we are going to go back and look at these methodologies, if we are going to shower students with lectures all day long, and at the end of the day, if they go home and their father will ask them, what did you learn? They would say, well, we learned nothing because they didn't allow us to learn. They were talking to us all day. And they will be right about that. But aside from the anecdotal issues, there are some scientific evidence about the effectiveness of different methods of teaching. That is done by national training laboratories in Badajoz. So according to this learning pyramid, if you look at the retention of knowledge after 3 months for lecture is only 5%. And for reading book is 10%. If you add audiovisuals, 20%, and it goes on. And if you see the highest level of knowledge retention remains with practice by doing, which is based on experiential learning. Now, all these other methods that you see here belongs to the philosophy of behaviorism and cognitivism. The only one that is here very effective is based on constructive theory of Piaget. So Piaget is actually, you probably know him very well, a Swiss pedagogue and philosopher who is the father of the theory of constructivism. So what Piaget said is that learning is secondary to and dependent upon progressive reorganization of cognitive function. To teach, Piaget said, is not to reshape behavior, but to provide the environment for self-exploration, an enriched environment for self-exploration. Also, Vygotsky, another Russian pedagogue and philosopher, brought this theory, expanded this theory actually further into social constructivism, because he believed that teaching is a social event. It happens, we learn from each other. It cannot happen in isolation. Both of these theories of constructivism and social constructivism are the basis of our medical practice that we do every day, medical teaching that we do every day. And that is, if we can just go back and think, how do we as clinicians, we come to a diagnostic or management decisions? Research has shown that we do four types of thinking. It's reduced thinking, dispersed thinking, elaborated thinking, which is based on deductive reasoning, and compiled thinking that's based on recall, recognition, memory. Now, I'm not going to talk about these two, but elaborated thinking is mostly used by clerks and residents in their early education years, because that's how they come to decisions. But when a doctor graduates and for 5-10 years working, they don't think about elaborated thinking anymore. They their basis of thinking is compiled thinking, which is based on recall recognition memory. So in recall recognition, memory is based on constructivism theory and experiential learning. So the more you see cases, the more you repeat those cases, the more you remember about them, rather than coming to conclusion toward, from deductive reasoning point of view. But the whole area of recall recognition memory in philosophy and pedagogy is coming from Hofding theory of conceptualization of recall recognition memory. So what he was saying is that when a prior event occurs, A, this prior event would have store some information in our brain that we call it a small, that triggers an internal response and an outside response of B. Now, based on this theory, a lot of people have developed theories for transfer of learning. One of the theories of transfer of learning is called environmental theory or theory of identical elements. So what that means is that when a prior experience A is happening, they say that the new experience that comes to you has to be identical to the prior experience in order for you to trigger the response. To tell you the truth, most of our curricula from elementary school to colleges into universities are based on the theory of identical elements. But a lot of people are coming and saying, no, that have an argument about this, and saying, yes, that would be okay if A is always constant. But A is not always constant, because the new experience that you get, it might be a variation of A asterisk, or something else. It's not really close to A. So the question becomes, will the variation of A would trigger the observable response B? No. If yes, then what are the conditions in the governing, the likelihood of that to happen? So in order to answer this question, some other philosophers came up with the theory of cognitive theory of transfer of knowledge. What cognitive theory of transfer of knowledge is saying is that the response B is not on the basis of identical elements. It's on the basis of conceptual similarities. It doesn't have to be identically similar, but conceptually similar. And they developed this theory on the basis of this scientific method. So they say that the prior knowledge goes through all these things to conceptualization and through the short memory to the long memory. And in the long memory, we have also the nodes and semantic networks and in all pathways that connects that. And this semantic network is actually responsible for the conceptual similarities. So when the new event comes and goes through the same pathway, when the brain sees conceptually identical elements, then it would give the information to the response, and then we go to problem solving. It moves things to problem solving. And so the classical pedagogical method that we use in medicine, such as see one, do one, teach one, that we said is based on experiential learning, is now we know that experiential learning or repetition of identical elements or repetition of similar elements would bring the compiled thinking, would make us, would improve the recall recognition memory that affects our medical practice. Now, therefore, see one, do one, teach one, apparatus model is a good model. It's not a bad model. We don't say it's a bad model. However, there are some obstacles at this point for this model. And the obstacles are the patient availability. We know that when the residents or clerk is coming to the ward, you'd always not have the same cases that you want to show them. It's also may not be ethical to give a first-year resident or second-year resident something to do independently. And also, there are legal consequences and cost consequences. So therefore, what would happen here is that with our present method of teaching apprenticeship model, we need 3 years for residency training program to slowly develop skills to a threshold that the residents could be independent. Now, what it would do with our education system, it would make it unsafe, costly, inefficient, and unreliable. Now, if we go and introduce simulation into the same equation, and we say, see one, simulate 100, and then do one and teach one, simulation actually proven to improve your recall, recognition, memory by bringing identical elements to you repeatedly and repeatedly, or bringing similar elements to you repeatedly and repeatedly. And improve of experiential learning out of the clinic in a laboratory condition would improve our compiled thinking, and that can affect our medical practice. Now, if you choose this method, then what you would do with our medical system, our educational system, is that we bring the threshold of independence much more closer to the left side, and we make residents prepared much earlier, and maybe we reduce even their time of training. And therefore, medical education could be safer, cost-effective, efficient, and more reliable. Now, before I finish this part of my talk, I would like to pay your attention also on one other shortfall in our education as a whole, and that is the efficiency versus innovation. All our methods of teaching, we pay more attention on efficiency than innovation. All our methods of teaching are based on efficiency. We prepare students to finish medical school, to finish residency program. We don't prepare them to prepare them for life, because all our methods are imposed for advocacy of efficiency, not innovation. And therefore, but if we are going to bring the advocacy and innovation together, then the adaptation corridor would be much wider, and we prepare actually students for life. And that can be done only in innovation part, only can be done in the simulation environment. So simulation would become a more effective environment for teaching. Now, to conclude my first part of the talk, I have to say that transfer of knowledge is very important for simulation environment, but we have to be very sure that transfer of knowledge is not based on cognitive or cognitivism or behaviorism. That is based on constructivism. Now, we don't want the professors and instructors to turn simulation events into a seminar or a lecture. The second important thing is that we have to look into the transfer of learning. The transfer of learning, we have to look not only in the theory of identical elements, in vertical transfer, we look also into lateral transfer. And also make sure that innovation is taken into consideration when as much as the efficacy is taken into consideration. The other issue is that a lot of people think that transfer of knowledge is the same as transfer of learning, and it is not. Transfer of knowledge is from one person to another person, one subject to another subject, and transfer of learning is from the same subject to the same subject between prior and in newer experiences. And also, in the end, I would like to also, in the end of this part, to tell you that when you design curriculum for medical school, we should not think anymore about creating curriculum for simulation. We should think about integrating simulation in all level of medical school training and residency training program. So simulation is a tool. It's not a separate method of teaching. And also, in the curriculum development, we should think more about the holistic approach of simulation curriculum, not stick into the competency and skill simulation, but to stick into a patient-centered simulation. Now simulation is used in other industries also, like the police forces are using simulation. Before, what they did is they target shoot, and they got policemen who has the best target shooter, but in a night time, during the rainy season, with a lot of cars and noises going around in an environment that is very volatile, they don't perform as they should, even if in targeting they're the best target shooters. So therefore, they are using now simulation not just for target shooting, but to shoot in an environment that is more like a real life environment. And why don't we in medical school or medical training, we don't use the same philosophy as the military and the police forces are using? So the second part of the second factor that is very important, it's the design and integration of the criteria for the effective teaching. And in that shell, it's not different, actually, criteria from classic teaching into simulation teaching. There's a lot of similarities, but there are some differences. If you look at the teachers or product, we can say teacher management indicators or teacher instructional indicators, or in the product, we look at the teacher product indicators or the student achievement indicators. When you look into all these issues, the first part, the teacher management indicators, are probably the same as you can see here. So you have to prepare you have to do the routine. But when it comes to discipline and learning environment, in a simulation environment, you have to do more. Because the students, you shouldn't let them know that this is, a doll, we are playing with a doll and they're loose. They have to think that it's a very serious environment, and in this serious as clinical environment, so you have to have extra attention there. And also learning environment. For a lecture, that you need slides, you need chalk, and you need a blackboard or a whiteboard. But for simulation, you need a lot of things, a lot of materials, like IVs, like defibrillators, like instruments, and so on and so forth. So we have to make sure that you have all those things for simulation. These other indicators are very important to think of. I don't have much time to go through all of them, but I have to tell you one thing, that the difference between a classic teaching and a simulation teaching is that in simulation, we let people develop their own skills. We let people understand their own problems, their own mistakes. So therefore, we don't do guiding like do the classicals. We don't do nurturing like in classical teaching. We don't give them things ahead of time, because if you give the case ahead of time, then there is no fun of doing simulation. So those are the differences in the instructional indicators. And then the most important other part is the teacher's product indicators, which is a plan of lessons. All that is the same. You have to have students' files. Actually, in simulation, we have all electronic students' files, so it's much better. And also, we have to know that we have to change the culture of teaching in simulation from classic simulation, because classic simulation, as we talked, is based on efficiency. We're testing and over-testing and quizzing and all that. But simulation environment is a non-threatening environment. There is no testing. There's our evaluation and assessment that we will talk about later. Now, so to come up with the second summary of my second factor that affects the teaching and a simulation environment, that pertains to the design of the criteria for effective simulation, I have to say that the most important one probably is to have a clearly defined learning objectives. Without that, nobody should go to the simulation room. And then you should have the performance and feedback by qualified individuals, by experts. And also debriefing, you should have after the session, not only by experts, but experts, subject matter experts, but also experts on the debriefing. And there is slight difference between performance feedback and debriefing. Performance feedback is when we directly say to the student, this is what you do wrong and you have to change it, you do it this way. But debriefing is a method of supporting the students with open-ended questions for them to come to their own conclusions about what they have done wrong and what they should do right next time. And then peer review evaluation is also a very important one, and we can do it in simulation, but not in other methods. Self-assessment is another method. We videotape all our students. Why not let them watch their videotapes and think what they did? Where did they go wrong about it? And the most important in the end, I would like to pay attention to you, is that that would change the culture of education, which is failure is not, in the classical method, failure is failure. In simulation, failure equals success. Nobody fails in simulation environment. Actually, failure is not only allowed in simulation environment, it's desirable in a simulation environment, because let them make all those mistakes in a simulated environment and learn from it than to go to the clinics and do it with patients. And then also change from testing and evaluation to teaching and learning. So we spend more time in teaching and learning rather than evaluating, testing, and it should be very, the simulation environment should not be penalized environment. There's no penalty in that. So having said all that, thank you very much for your attention, and that's the sunrise in Vancouver.